Okay, everybody. Moving on, chapter 16, general pharmacology. So this study of the medicines that we can get, that we can give and administer. Um, so as an EMT, we definitely can give some medications now, which is a great thing. From things that we can administer, and then also IV therapy that we're able to do as well. So it's kind of cool. So in this chapter, I'm going to go definitely by test purposes, registry purposes. Um, According to our protocols, we have some different scopes, which is in the chapter. It talks about. So there's two types of medications. There's standing orders, which means that we can give it. It's a standing order from our medical director. Um, Things that we can give, and then there's things that we have to call in to give and get permission. Um, so anyway, some medications on the ambulance is right here listed as aspirin, oral glucose, oxygen, and activated charcoal. So aspirin, obviously we give to people with that looks like they're having a heart attack. A lot of people take it obviously for pain or for headaches to treat a fever. I have given aspirin in the field for fevers, but the main thing is that we can do it for people with chest pain. And what it kind of does helps is it keeps the blood from clotting since it's a blood thinner. So we do give chewable aspirin. We carry it in ambulance. I've given it many times. So just read your section on there in your chapter um, on that. But basically, just so you know, we can carry it. It's 81 milligrams a tablet for baby aspirin. So we give up to 8 tablets on the way to the hospital. Um, that is a standing order. We don't have to call in for that. Well, then there's oral glucose, which is a sugar type of sugar, and we give that for diabetics that are obviously having low blood sugar. It's for patients that are conscious. So one of the verbiage in the book and in the test are contrary indications. So a contrary indication to oral glucose given it would be if the patient's unconscious because they can't swallow. So basically we just open that up and we pour a dose into their mouth or rub it on our finger and rub it into their mouth, but they kind of just drink it and bounce back. Usually will help them on a way. I took a patient one time that had a blood sugar of 35. Found him over at Sereno Road on the west side of Kit Carson and gave him 2 doses of oral glucose, and he was up in the 70s before we got to the hospital. Oxygen, which we all know it's a gas commonly found in the atmosphere. Pure oxygen is used as a drug to treat any patient whose medical or traumatic condition causes him to be hypoxic. Um, so basically, if there's hypoxia in the mix, so their pulse ox is reading below 90, in my opinion. I think your book said 95, so test purposes follow your book. But really, 90 to 94 is a good pulse ox to me, and most people, obviously. And then under 90, I start putting them on liters of nasal cannula. But so anyway, so oxygen, and then we have activated charcoal for overdoses. People that swallowed um, chemicals, pills, that kind of thing. So if someone took too many opiates, we do Narcan, but then we can also do charcoal. And what charcoal does is pretty cool. It binds the toxins to the charcoal. It's made from wood, so charred wood, and so the toxins kind of band to the charcoal and keeps it from absorbing into the body. And anyway, it's a pretty cool drug. Or I've used it once in the field, and honestly, there's a lot of purposes for it. You'll see it a lot in the ER. One thing that would be contrary is anybody it does cause people to throw up. So if they drink antifreeze or something that's going to burn their insides on the way out, we don't give glucose because there's a good chance of vomiting. But primarily, like I said, opiates, things that they swallow, if it's in their digestive tract, we can throw some charcoal in them. It's usually mixed with liquid. What we carry is mixed with liquid, so you just pour it into their mouth or pour it into a glass. Bronchodilator. A lot of people carry asthma. If they have issues, they'll carry asthma inhalers, nebs, stuff like that, albuterol treatments. So basically, where we work with that is if we show up to a patient and they have a medical condition and they're struggling with it, we can assist them with their inhaler and make sure to wash them, giving it. We'll go through some stuff that we give, like we can do CPAP, we can do albuterol now, um, but that's in our scope. So Bronco inhaler, so it's just a gas that is in their inhaler mixed with their own albuterol and or whatever they carry. And anyway, so one thing you want to watch with this when you do assist them with their inhaler is watch their heart rate and their pulse ox, because a lot of times it'll cause tachycardia a little bit. They'll get a little bit excited, their heart rate, they get jittery, they get anxious. So we want to watch that, but we want to actually call medical direction on that a lot of times. Get medical direction to help assist them with their inhaler. Um, but like I said, our protocols are different in our area versus others. So just read your book, follow it for test purposes, and then we'll teach after you pass how we do things here according to our medical direction. Um, but prescribed medications that we can assist with. So there you go. It's an inhaler, nitroglycerin. So we can't give nitroglycerin unless the patient has it prescribed to them. And then we can help them take their nitro. So if you show up to someone who has chest pain, looks like a heart attack, we give aspirin to thin the blood, but nitro dilates the veins to help that blood keep flowing so it don't clot or nothing, so that doesn't happen that way. So if they're on nitro, we can assist them with theirs, and the same thing with their inhaler, and then epinephrine. Now that's not talking about anaphylactic epinephrine, and that because we can administer that. But if they're carrying an EpiPen, we can assist them with theirs. Um, but I think epinephrine. I'm looking in the book right now for you. I do believe in our scope, because of our medical director, we can carry epi. We're waivered for it, and it is a standing order if there's an anaphylactic shock. But you want to make sure to be clear in your book on what the test is looking for in that aspect, because not every area nation. So the National Registry is a nationwide test. Not every state's the same. So but it says in your book, because severe allergic reactions may reach a life-threatening stage in a very short time, epinephrine must be administered quickly. Many patients who are prone to severe spring-loaded or allergic reactions carry an epinephrine autoinjector, and it's a spring-loaded needle that will release and inject epinephrine into the muscle when the autoinjector is pushed against the thigh. So you may need to seek permission from medical direction, or there may be a standing order permitting you to assist a patient who has an epinephrine autoinjector. So basically, it's stating, remember that for the test purposes. So our protocol here, though, is our medical director has waivered us, so we carry epinephrine in the ambulance, and we can assist a patient that has an autoinjector, but we carry our own and we draw it up 0.3 liters for an adult, and we inject it ourselves, primarily because of cost factors. It's more cheap. It's cheaper to use vials and draw it up ourselves versus it's like $800 for one auto pen, and we don't do enough of that to justify the cost. But just so you're aware, it's 0.3 liters for an adult, and that we can assist them, but also we carry it, and it's a standing order. But for test purpose, remember that that you may have to call in for permission. So it could get tricky on that. So, anyways, nice things there. So, bronchodilator inhalers used in patients with asthma, emphysema, and chronic bronchitis. Enlarges, so basically when their airway is closing up, bronchodilator does exactly what it says. It dilates the airway, so it can help the patient begin to breathe. Side effects is increased heart rate and patient's jitteriness. Because it is a dilator, it will cause the heart to beat faster, and patient will feel anxious, and you'll see that. Nitroglycerin, we can assist with that. Like I said, it's chest pain and cardiac origin, so it helps dilate the coronary vessels so blood can flow. So again, nitroglycerin dilates, then aspirin thins. So the blood thinning can flow through the dilated veins and just help not having issues there. And then the other side too is contradictions, like if they have low blood pressure or they're taking medications, that will have a side effect if it's taken together. So Viagra, I mean, a lot of times you'll see people taking a lot of Viagra. They'll have potentially strokes in the future. So contradictions means that you're not going to help them with their nitroglycerin if they're already taking pills that cause a similar effect. So Viagra, Levotrol, Cialis, similar stuff. So make sure before you show up to a chest pain, make sure that they haven't already taken blood thinners, for example. But you can still give the aspirin because it's not going to affect them negatively. It'll help. But then before you help them with their nitro, make sure what drugs they're taking besides nitroglycerin. But at the same time, we can't help with that, or we can't give it. We have to assist them with theirs, and I'd always call for medical direction on nitroglycerin. Um, the side effect is dropping blood pressure, which is why a contradiction to if they're having low blood pressure already, you're not going to give them nitro. Um, and those drugs there listed that I talked about will lower blood pressure. So blood pressure too low, you don't want to give nitro. Um, epinephrine auto-injectors, we just covered that a little bit. So it's prescribed, used for patients with severe allergic reactions. And like I said already, we carry that, so we can assist them with theirs, or we can just give them ours. Um, it relaxes smooth muscles in the airway passages, so people can continue to breathe. So anaphylaxis, they're constricting. You'll hear wheezing. You'll hear the effects of it, and then eventually they'll go into respiratory distress and then arrest if potentially if not taken care of. Increase heart rate and blood pressure. So it's going to increase that heart rate because it's epi. It's exactly what it is. We give this to cardiac arrest. So it's just going to get that heart beating and it's going to increase their blood pressure at the same time because the heart's beating, blood's flowing. They're going to have some energy. Other drugs that may sometimes be administered. Naloxone. It's an antidote for a patient who is unconscious and in respiratory failure after taking a narcotic. So naloxone, another name that you'll hear us talk about in the field all the time, is Narcan. We do carry this and have administered it in our county. So basically, anybody that's taking too many opiates, they're going to go unconscious and then possibly go in respiratory distress and then arrest because it's just it's knocking everything out basically. So basically, if they're unconscious, everything's slowing down. Their respiratory rate's going to slow down. So rule of thumb is when you show up to a call and someone's unconscious and nobody knows why, give Narcan. Maybe it was an opiate. Maybe they did overdose. We don't know for sure, but there's not really much negative effect to give it to an unconscious patient anyway. If it is a witness and someone says, "Yep, they took too many drugs," anyway, give them Narcan. But that does not work if patient has not had a narcotic. So if they're unconscious, you don't know why, you give Narcan, they don't wake up, there's something else going on, keep your assessment going. But never hurts to give that Narcan to make sure. Atropine is an autoinjector to treat responders in the event of an attack. So force protection medications. So atropine is an autoinjector to treat responders in the event of an attack. General information on the medications is each drug is listed by its generic name. Each drug has at least 3 names. So this is where it gets kind of tricky, and definitely be reading up on this. This is all going to be test questions. But chemical name and a generic name, and then a brand name. One or more trade names given to the drug by the manufacturer. So just different kinds of names that the manufacturer gives. So there's always, you guys know, if you ever took prescriptions, right, you look at your bottle, there's the name of the actual chemical name, then there's the generic name, right, that you actually get. So, for example, I'm on Singular for allergies is a prescription I get, but it's not Singular, it's a different name, it's a generic name. So, just read up on those. Just read up on those in your book because those will be test questions. What you need to know when giving a medication is the indications, and then you need to know the contradictions. So, for example, like I said, with the contradictions, basically what that is anything negatively going to happen because of the drug. So, like, you're not going to give it, so you're not going to give nitro to people with low blood pressure or on low blood pressure medication or medication that lowers blood pressure because nitro is going to do that as well, and it'll be negative. So you want to always look at those things, and then also the side effects. What are some side effects? Like we said with epi, they're going to be tachycardic and their blood pressure is going to rise. With inhaler, bronchodilator, they're gonna have jitterness. They're gonna have a tachycardic and be a little bit of excited and anxious. So always know the side effects of the meds, so you can also explain that to the patient, but also know the outcome. And then untoward effects. What is coming up next with those effects? So what you need to know when giving a medication is the form of the medication, compressed powders or tablets. So aspirin is chewables, so it's a tablet. We give you know Zofran in the ambulance. So if someone's nauseous, we give them a tablet. It's under the tongue. We got the liquids, the charcoal. It's a liquid. Glucose. It's a gel. Really, it's kind of like they drink it and chew it like syrup. So it's kind of a gelish form. Gases, which is the oxygen. Sublingual sprays. Some nitro is sublingual, so that means by the mouth. So you spray it on the tongue or under the tongue or in the mouth. So you need to know the forms that you're giving them in. For test purposes, I think you're all gonna know that anyway when you're in the ambulance giving drugs. But at the same time, it helps to know because you're gonna be in a hurry. Sometimes with these things, you got an unconscious patient and the respiratory rate's crashing. You're looking at that Narcan quick, so you gotta know what it looks like and um, that great stuff. Medication safety and clinical judgment. Administering or assisting with medications is a serious responsibility. Obviously, any drug we give. So the thing is, we don't give drugs. We're not ALS, we're BLS. So we're not giving drugs that are going to necessarily cause death. There's side effects to them, but it's also a very serious deal. I mean, every time you give a drug, you got to note the time you gave it and why, because it is a serious thing. I mean, giving that baby aspirin, is it going to hurt them? Well, potentially. If they're on blood thinner already and you didn't pay attention and you gave them more blood thinners, it could cause more problems, right? So every drug we give, big or small, we don't think of it because at home you got baby aspirin, you're not worried about it. But when you're now in a medical license giving these drugs, it's a serious thing. So you got to know the medications. Don't just take my word for it in this chapter because I'm trying to teach it quick as I can, but also give you the details. But also memorize as much as you can this chapter and all the medications and the side effects. It is in the test. It is a serious deal. So use good judgment as well when you're giving those drugs. If you have an unconscious patient that's diabetic and they're low diabetes but they're in a coma, you can't give the oral glucose. What are you going to do? Use good judgment. Now there's also IV. It's called D50 and D10, and you actually got to mix that up in the back of the ambulance and give it through IV form. But that's what you give. So use good judgment as your medication. Don't give, if you're going to give baby aspirin, right, it's 81 milligrams. So really to get the dose that we need in an adult, good judgment is about 8 tablets. Don't be quick and give 1 tablet that doesn't make a difference, but also don't give 15. That's going to cause more problems. So just use your good judgment, and it's common sense, as you go forward. But don't be scared to give it, but also treat it with the respect that it deserves. Medication authorization. So offline medical direction. Do not speak to a physician, and it's a standing order. So that's kind of what I was sharing with you on some of the stuff that we have. We can give a lot of stuff now. I mean, by standing order. I mean, it's ridiculous. Like one of you guys said that took EMT class 15 years ago. It's a whole lot different ballgame now. So basically, offline is standing orders. You're gonna have to know when your page goes off. You're gonna have to know what drugs you can give by standing orders, and then online medical direction, where you have to speak directly to a physician, listen to order, then repeat the order back to them, and ask for clarification if necessary. But that's where you have to call for medical direction. Very little drugs that we have to do that with now, and it never hurts at the same time to call in and just confirm. I'd prefer you to do that than be quick to think and make a wrong call. But the fact of the matter is you don't have to call for a lot of things, but when you do, make sure to be clear. This is what's going on with the patient. Let's say you're thinking you're going to give some albuterol. So make sure to explain the pulse ox, the respiratory rate, the appearance of the patient, the wheezing or whatever you're hearing when you listen with the stethoscope, and then repeat back to the doctor what he just said to you so you know and he knows you're on the same page when you give that drug. 5 rights. Do I have the right patient? So when you give medications, especially when it's the patient's drugs, do I have the right patient? Is it the right time to administer this medication? And so these are just good questions to protect yourself with. Um, and then is the right medication? You always want to make sure that. So do you have the right patient? Is it the right time to administer the patient according to the prescription? And is the right medication? And is the right dose? And am I giving this medication by the right route of administering? So those are just some 5 rights that you can do when you are working with your patient to give medication, to make sure you're giving the right stuff. Because even if it is prescribed to them, make sure you're following the instructions. So a think about it question is, what would be the potential risk to the patient if each of the 5 rights were not checked prior to administration? So just go back and think about that. So one, if you don't have the right patient, they could have a bad side effect to the drug because you don't know the patient history. The right time, is it the right time to give it? So I was on a call one time with a COPDer, um, you know, and he already took albuterol. So I wanted to call make sure, is it too early to give the albuterol again? Because if you do it, what's the side effect if if it's the wrong time or the right medication? And I have seen this. I have seen where paramedics have given the wrong drug thinking it was something else without asking the question, is this the right one? Is the right dose? So what are some side effects that could happen? The right routes of administering, so oral or swallowed. A lot of stuff we give is oral, sublingual, or dissolved under the tongue. So our Zofran, I can do IV Zofran, but honestly, I haven't had a whole lot of time to do that when I'm in Shine Wells or whatever. But when I'm in Kit Carson taking a patient, I always have plenty of time to get the IV, get the fluids going, and that's a good time to give some Zofran by IV. But more times than not, I'm doing it under the tongue, sublingually, inhaled or breathed into lungs as tiny aerosol particles, such as from an inhaler or gas, such as oxygen. That's the right route to administering oxygen. Uh, Intranasal or sprayed into the nostrils. Um, Narcan goes through the nostril, so you're not going to spray it in the mouth, you're going to spray in the nostril, right? So intravenous or injected in the vein, which we were just talking about with the Zofran, and the D50. Those are primarily the 2 drugs we'd give by IV besides just sodium chloride, which we give, all the time, natural saline. Routes of administration, intramuscular or injected into a muscle, so epinephrine, that's where that's going to go. Subcutaneous or injected under the skin. Um, intra, intraosseous or injected into the bone marrow cavity. That's where epi is going to go. If you have a cardiac arrest, you do an IO, drill right in the bone and inject it right through right in the bone marrow. That's more of a critical patient. That's not anything that you'll do in the field per se, unless you're with a paramedic. But if you have a cardiac arrest and you're on your way to the hospital and you're working that patient, that's a great time to get an IO going and get some fluids going right into the bone marrow. Endotracheal or sprayed directly into a tube inserted into the trachea. So that's an ALS procedure there. So age and weight-related considerations is study of effect of medications on the body. What effect will medications have? How will this medication affect my patient specifically? And patient-specific factors change how medication works. So you want to look at all these things right here are good questions to ask before you give a drug. Is the weight, the age, because a lot of times, so like I said, like for example, for an adult, 150, 180, 200 pounds, an adult is 0.3 milliliters of, or zero point 0.3 of epinephrine, but to a kid, it's less, it's like 0.01. So just some good things, like I said, it's 0.01 or something for a kid with epinephrine. So always look at the weight, look at the age, how's it going to affect that age, how's it going to affect, and, reassessment and documentation. After administering medication, reassess the patient. You give epinephrine, reassess the vitals, the airway, how are they doing, and note all the changes going on. Clearly document medications administered. Do not forget to do that. You give Zofran, you write down the time that you gave that Zofran. And then you can also note that in 5 minutes you reassess, patient was feeling better. So documentation, reassessment. This are some medications that patients often take. Advair, which is the bronchodilator. Um, you can look at that herbal agents and what they are sometimes used for. St. John's wort, depression. So when you're at someone's house, you get all less of the medication and natural stuff. Look at this stuff. Echinacea, um, is known to help with the flu, bacteria, cold symptoms. Garlic, high cholesterol. And I'm more a natural guy myself. I take more vitamins than I take prescriptions, so I've taken a lot of this stuff at some point. Um, but you want to just know that. So IV therapy, to breeze through this pretty quick here, is fluids and medications may be administered into the vein. So when you do that, so saline, catheter placed into the vein, cap lock placed over the end of the catheter. So basically, this is just stuff we're going to teach you when you do IV cert. But read the chapter and read the section on this. I don't want to go too much into it on how to do an IV because we're going to do that with IV therapy, and it's not going to be on registry on how to do an IV, but you have to know what you can do with an IV. Um, so the lot contains port for an administered medication, so that goes right onto the IV that drips the medication in, basically. So setting up an IV fluid administration set. So ways fluids and medications may be administered in the vein is a traditional IV bag, and we'll show it to you in class. It's just basically the dose of saline or antibiotic, whatever you're going to be administering. It hangs above the patient and it constantly flows fluid and medications into the patient through a hose. And you can control. It's called bolus. You control how fast or how slow you want that medication being administered. Clear plastic tubing connecting fluid bag to needle or catheter. So 3 important parts is the drip chamber, the flow regulator, and the drug or needle port. An extension set makes it easier to carry or disrobe patients without pulling out the IV. So basically this section of the chapter we're going to do some clinicals on. We'll do it in class. I'll have you guys actually set up a bag and work it. But right there you can see the dose bag, and it hangs above the patient. That part is the hose that takes the that's the drip set. It drips the medications in from the bag into the patient. You just poke it right into the bag, right there, and then you set the bolus, how many drips you want per minute, and it just drips on down just like that. And you see what's in his fingers there, at the bottom. That's how you flow the drip set. So basically, the higher you put that up, the tighter it's going to be. You can actually stop it, and the more you lower it, the faster it gets. Right there. Turn off the flow chart. Or flow. Turn off the flow. So maintaining is troubleshoot flow problems. You're going to have those at times. Constricting bands left in place by mistake. When you put a tourniquet on, take it off. Put a tourniquet on to get the veins dilated. Flow regulator left closed. If you close it, you got to remember to open it and then adjust it where you want it. Clamp closed on tubing. That's if you want to stop it, you clamp it shut. Tubing can get kinked and keep the drugs from going in. Very easy for that to happen. Line pinched under backboard. So whenever we do a trauma and we set up these IVs, there's times you will set IVs up in the field. If someone's rolled under a car, it's going to take them a while to get out, but you can really tell they need some fluid. Get that going. Do not hesitate. If someone's in a car and it's going to take a good amount of time to cut them out, and you can see they're bleeding out, you want to control the bleed, or they're bleeding internally, get that going. I made a mistake one time, to not do an IV. It took a good 15 minutes, I'd say, 10, 15 minutes to get the person out of the car. I should have I thought about getting an IV going, but it was pretty chaotic scene. It gets crazy. But by the time we got to the hospital, couldn't get an IV. The blood was sludge, and it was just a bad deal. So take the opportunities to do that, but when you do, make sure the line doesn't get pinched or trapped. And then adjust the flow rate properly. Monitor IV sites for infiltration. So basically that's where in the site, you want the fluid to go right from a steady flow right from the tubing through the IV into the vein. And every now and then an infiltration is when it ruptures out. Now the D50 or whatever you're given is now going into the body, not in the vein. It's going outside the vein and it's infiltrating the tissue. And that can be a bad day with certain drugs. So we always want to monitor those sites. So chapter review, just read through it. The drugs, aspirins, the glucose, everything that we can give. Pretty quick chapter, but pretty important one. So any questions, text me, call me. We'll be in class and talk about this as well. to see how things are rolling. But just because these are online, do not hesitate to ask questions, because I want to make sure you guys are learning these things to be able to pass your tests. So, all right, appreciate it. We'll talk soon, guys.